Hey guys, my name is Ganga. I'm a second year biomedical science student, and today I'm going to talk about the menstrual cycle. The menstrual cycle is something that's very familiar for us women. I want to talk about the menstrual cycle from a scientist perspective, from a science student perspective. So, the menstrual cycle is actually divided into two cycles. The two cycles is the ovarian cycle over here. So the ovarian cycle, from its name, as you can see, is it involves the ovaries. So the ovarian cycle primarily discusses about the ovaries, whereas the uterine cycle involves the endometrium. And the endometrium, to be exact, has two layers: basal layer over here. We also have the functional layer. As I'm gonna explain later, this functional layer plays a major role in the menstrual period. Let's move on to the ovarian cycle first. We have three phases, not simultaneously, but it involves the ovaries, as we said. So the first phase is follicular phase, and then we have the ovulation phase and luteal phase. And for the uterine cycle is menstrual, proliferative, and secretory phase. And the primary goal of the ovarian cycle is to release oocyte from dominant follicle and also to perform ovulation. Ovulation is that process in between that helps oocyte to move into the fallopian tubes and begin the process of fertilization if that's the appropriate sperm. Moving to the uterine cycle, the goal is simply to have the menstrual period. So that is when the endometrium thickens and sheds and bleeds, and we get, well, women get menstrual periods. The mic got cut off in the middle, so I'm just going to explain what I was talking about with this recording. The two cycles, ovarian and uterine cycle of the menstrual cycle, is divided between 14 days. 14 days for pre-ovulatory phase, and then we have ovulation, and then another 14 days for the post-ovulatory phase, where the uterine cycle and its role takes place. And I was also explaining about the four phases of the menstrual cycle. So the pre-ovulatory phase has the follicular phase, where ovaries are involved, and the menstrual and proliferative phase, which involves the endometrium, whereas the post-ovulatory phase has the luteal phase, which also involves the ovaries, and the secretory phase, which involves the endometrium. With the follicular phase, it takes place in the ovaries, where the first day of menstruation begins. The hypothalamus releases gonadotropin releasing hormone, to which the anterior pituitary gland responds to this by releasing FSH, follicular stimulating hormone, and LH, luteinizing hormone. After puberty, gonadotropin releasing hormone is released in pulses. The follicule, the ovarian follicles present in ovaries, where the outer layer is made up of theca cells, and we also have granular cells and the primary oocyte inside of the follicle. The theca cells out around the follicle develop receptors and bind LH and secrete large amounts of androstenedium, which is an androgen hormone. The granulosa cells develop receptors for this, and they bind FSH and secrete the enzyme aromatase. So aromatase converts androstenedium to 17 beta estradiol. So now we have the formation of 17 beta estradiol, which means more estrogen is gonna be released. So with a large amount of estrogen being released, this means that more follicles will continue to grow. But with the increase of estrogen, it will act as a negative feedback to the pituitary, and it'll tell the pituitary to stop producing FSH. With less FSH, more of these follicles are not gonna grow, and they're gonna continue to shrink and die. That is gonna be the follicle with the most FSH hormone in them will continue to grow and become the dominant follicle. So this dominant follicle will go on to perform ovulation, and will also continue to secrete estrogen. Simultaneously, the granulosa cells also develop another receptor which will bind to LH. So they produce LH receptors, granulosa cells, that is. And what happens is that this is gonna, so with more estrogen, it's gonna trigger gonadotropin releasing hormones to increase, which is gonna increase the amount of LH and FSH. So with this surge of LH and FSH begins usually few days before ovulation, and what it also does is that it ruptures the follicle, the dominant follicle, and with this rupture the primary oocyte or the oocyte can get released, can go out of the follicle and into wherever it needs to be, and in this case it's the fallopian tubes. For ovulation, which is gonna be the 14th day, as we said before, estrogen released from the dominant follicle acts as positive feedback to the pituitary. That is when, more of LH and FSH is being released, compared to the negative feedback that estrogen acted before. So coming on to the menstrual phase, as we said before, it involves the endometrium. So what really happens is that the this cycle or this phase starts by shedding the endometrial lining. So this is the endometrium, or it can also be the endometrial lining. So what actually sheds is this functional layer, and it sheds through the vagina, and it is called the menstrual period. So this shedding, also called the menstrual period, consists of 5 days. Usually it is for 5 days, but it can be more for other people or less. So the next phase, which happens right after the menstrual phase, is the proliferative phase. With the high estrogen that we still have, it stimulates thickening of the endometrium. So after it sheds, the lining sheds, the endometrium begins is thickening again, and the growth of endometrial glands, and also the emergence of spiral arteries. So what are spiral arteries? Here I've drawn a symbol diagram where it's like this is the function layer and this is the basal layer. Spiral arteries in the basal layer helps the functional layer of the endometrium to function. It helps with supplying the blood, helps with pregnancy. It also helps with contraction to control blood flow. So in the luteal phase, we are going to talk about which happens post ovulatory period, which is after ovulation. So what happens is that now that the primary oocyte has been outside of the follicle goes through a change. So it becomes corpus luteum, where we have luteinized theca cells and luteinized granulosa cells. We have low levels of, so as I mentioned before, in luteal phase we have low levels of LH. Luteinized theca cells do secrete androstenedium, and luteinized granulosa cells also secrete 17 beta estradiol. But with low levels of LH, luteinized granulosa cells also increase the activity of P450 SCC, so which is the cholesterol side chain cleavage enzyme. And what this enzyme does is that it converts cholesterol into pregnenolone, and this pregnenolone, it's a precursor of progesterone. So we essentially have more progesterone than estrogen in luteal phase. So L granulosa cells make more progesterone, but luteinized granulosa cells also make inhibin, which inhibits the release of FSH. So progesterone acts as a negative feedback to the pituitary by saying, hey pituitary, release less of LH and FSH. So both of these processes increase decrease estrogen levels, so progesterone levels are increased in the luteal phase. So with high progesterone, this makes the endometrium less receptive to fertilized gamete. Coming on to the endometrium, we have the last phase, which is the secretory phase, where as you can see, I've drawn the basal layer and the function layer. So the spiral arteries of the basal layer becomes more like grows and becomes more coiled. The uterine gland starts to secrete more mucus, and after the 15th day post ovulatory period, that's when the window for fertilization begins to close, so chance of pregnancy becomes even lower. The corpus luteum, so the last thing that happens in this post ovulatory period is that the corpus luteum is replaced by corpus albicans. So corpus albicans don't really secrete hormones, so the levels of estrogen, progesterone decrease. So with progesterone starts to decrease, the spiral arteries collapse and the function layer starts to shed through menstruation. So now the menstrual cycle begins again as it is a cycle, but it does not end here because I am going to talk about a special topic that I am very much deeply interested in, which is endometriosis. So endometriosis is a chronic condition affecting 1 in 10 women, menstruating women. So, what happens in endometriosis is that the endometrium, so as I've said over here before, the endometrium has the endometrial lining, is the endometrial lining. When it sheds and it starts to regrow, it regrows in different areas of the body. So endometrial tissues that grows outside of the endometrium, like the ovaries or the peritoneal cavity or the pelvis, that is when it starts to become a problem because it starts to inflict pain on the body. And these things that grows outside of the endometrium, they are called lesions, and these lesions, they respond to hormones normally, but because of that, during normal menstruation, lesions that are present outside of the body also shed, and that can produce period pains or non-cyclic pain, pelvic pain, also called CPP, chronic pelvic pain. This abnormal bleeding where lesions shed can also cause blood in the urine and stool. So I'm just gonna bring my laptop over here. The symptoms of endometriosis is not just pain, but I am gonna focus on pain in this video because that's what I am deeply interested in and care for. So as I've said before, we have chronic non-cyclic pain. So this is the pain that happens outside of menstruation. It is not according to the menstrual cycle. Instead, it occurs due to adhesion. Adhesions happens when after inflammation and bleeding, the body starts to repair itself by forming scar tissue. This scar tissue acts as adhesions. They stick nearby organs together, causing pain. So, for example, the adhesions on the ovaries and the peritoneum can stick together, and that can cause pain for the individual. We also have menstrual pain that increases a lot. They're called chronic cyclic pain. Now, we don't really know what is the pathogenesis of endometriosis, what causes endometriosis, but we do have some theories. One theory is retrograde menstruation. So this is when menstrual blood, instead of moving outside of the vagina, as we said previously, it moves backwards into the fallopian tube, and that leads to endometrial lesions. There is also theories where dysfunction of the innate immune system can lead to endometriosis. Metaplasia of specialized cells in the peritoneal cavity, as we said before, leads to endometriosis. For treatments, laparoscopy surgery is done to reduce infertility issues and increase the chance of pregnancy. This is also the gold standard for diagnosing endometriosis. We also have drugs that can reduce pain. There is a lot. There is also staging of endometriosis, from stage 1 being very small and superficial to stage 4 having like deep and large lesions. So those are like really bad. I would like to do a separate video just for endometriosis because this is something that I'm very interested in. But that is it. Thank you guys for watching me talk about the menstrual cycle and endometriosis. I'll catch you on with the next one.